Hello, everybody. My name is Doug Golub, and I am from MediSked. And I'm very thankful to be able to introduce today's panel. I'm thankful to the National Association of County Behavioral Health and IDD directors as we are exploring the intersection between intellectual and developmental disabilities and behavioral health. We all know that people with disabilities make the best employees because they can learn to adapt outside the box and be able to persevere and hopefully thrive in a world that wasn't built for them. We also know that embracing intersectionality enables diverse perspectives and includes everybody. But today's conversation isn't exactly about DEI, and it's not exactly about employment outcomes, and fortunately, it's not about ableism either. It's about adapting to a world of community-based services that aren't exactly designed for you. We're going to look at strategies and solutions, and our panelists will take a look at federal, state, and association and community levels for people with intellectual and developmental disabilities, but also dually diagnosed with a psychiatric or behavioral health diagnosis. So these service systems are often designed for one of those diagnoses, but not necessarily concurrently for both. And professionals estimate that there may be about 40% of the people that we support with an IDD diagnosis through the Medicaid waivers and other state plan services that also have a mental health diagnosis. Today, we'll talk about policy and policy relics, especially during the time of a national mental health crisis, a workforce crisis, a criminal justice crisis. We'll talk about training for the staff and clinicians in a behavioral health world for people with IDD. We'll also talk about beliefs, beliefs that people that are dually diagnosed can or cannot benefit from certain therapies. I started my career as a DSP, and we'd also often hear this double entendre of, especially working with certain individuals, do you know what this person is capable of? So the positive meaning of that sees a person in their best potential, sees them able to thrive and live the life they choose. The other meaning is that this represents attitudes and roadblocks that are barriers to people truly thriving. And so as change is constant, we'll be hearing from top experts on these strategies and solutions, from promising practices all the way through to opportunities that come up with MCO reprocurements. You'll find something in common from our presenters today. Changing hearts and minds and policy isn't always easy, but this panel of experts are working day and night to enable the best supports for people that are singly diagnosed and dually diagnosed. And so let me introduce to you our presenters for today. First, we have Jennifer Johnson, Deputy Commissioner of the Administration on Disabilities at the Administration for Community Living at the U.S. Department of Health and Human Services. She'll be followed by Mary Sowers, Executive Director of the National Association of State Directors of Developmental Disability Services. After, we have Nancy Kelly, who is Branch Chief, Mental Health Promotion, Division of Prevention, Traumatic Stress, and Special Programs at the Center for Mental Health Services, Substance Abuse and Mental Health Services Administration, or SAMHSA. We'll also have, from a local level, Sherry Arbuckle, who is the Service Access and Operations Director at Sedgwick County Developmental Disability Organization in Kansas, and she'll be speaking alongside Nick Wood, Associate Director of InterHab, which is the predominant voice and association for persons with IDD, families, providers of services and supports in Kansas. And finally, Jonah Cunningham, CEO of the National Association of County Behavioral Health and Developmental Disabilities Directors. And so with that, we have first Jennifer, and it's my high honor to hand it over to Jennifer. Welcome, Jennifer.
Thank you, Doug, for that introduction, and good day to everyone. It gives me great pleasure to join my esteemed colleagues on today's webinar. As was mentioned, I am Jennifer Johnson, and I am the Deputy Commissioner for the Administration on Disabilities here in the Administration for Community Living. Just to give you a visual, I am a middle-aged white woman with gray hair. I have it pulled back in a ponytail, and I have on a white shirt under a tan cardigan, and I'm also wearing dark rimmed reading glasses. I have a virtual background, which is blue and has the ACL logo on it. For those of you who aren't familiar with the Administration for Community Living, or ACL, as we call it for short, like I said, we are part of the U.S. Department of Health and Human Services, or HHS, and we fund disability and aging organizations that help to support people with disabilities and older adults to lead and live full lives in the community. So we also work on preventing them from going into institutions by focusing on supports for living in the community. Over the years, we have really witnessed decades of progress for people with intellectual and developmental disabilities, where they have more opportunities to be fully active participants in their communities. Yet despite that progress, we all know that there are many barriers that still exist for people with IDDD to be fully included as value members in all aspects of community life. And in most cases, these barriers are caused by biases and societal beliefs that have created low expectations about what people with IDDD can do and what they can achieve. And what these beliefs have done has led to devastating results. We see people with IDDD experience higher rates of poverty and homelessness, lower rates of employment and educational attainment, and poorer health outcomes. And when we consider those kinds of outcomes for people with co-occurring IDDD and mental health disabilities, it's doubly, triply, quadruply true for those people who experience co-occurring IDDD and mental health disabilities in terms of the poor outcomes that they experience. Research shows that people with co-occurring IDDD and mental health needs are more likely to be institutionalized and are often the last to get out of institutions. And this exclusion from community living oftentimes begins when these folks are in school. We took a look at data from the National Core Indicators Consumer Survey, which has found significant differences in outcomes between individuals with and without co-occurring IDDD and mental health disabilities. And their data has shown that people with co-occurring IDDD and mental health disabilities were more likely to live in a group home than an independent living setting. They were also more likely, they were somewhat less likely to be in excellent or very good health. And while there was no significant difference among employment rates between these groups, people with co-occurring IDDD and mental health disabilities earned less income than individuals with IDDD only. And individuals with co-occurring IDDD and mental health disabilities were less likely to report having friends and were more likely to report feeling lonely. As I said, when we look at the IDD population in general, and then we add to that the mental health disability, we see an intersectionality for individuals which does greatly impact the quality of their life and their overall outcomes. And then when we add to that further intersectionalities such as race and ethnicity, where somebody may be living or their socioeconomic status, then again, the challenges just really compound for them. There are a number of difficulties in serving this population and serving them well. And one of those difficulties in supporting this population is that we don't know a lot about the prevalence of co-occurring IDDD and mental health disabilities, which makes it hard to adequately plan for services and supports. We don't have good data or prevalence rates because of issues with a lack of reporting across siloed service systems. And there is variance in the way these disabilities are defined. And there's also what we call diagnostic overshadowing. And those are just some of the reasons why we don't have good data. There have been ranges that have been as low as 30% of the population has both IDDD, or 30% of the IDDD population also has mental health disabilities, to upwards of 70% of the population has mental health disabilities. And despite the fact that there are several sources that suggest individuals with IDDD experience higher rates of mental health conditions, it is shown that they experience those across the lifespan, regardless of what data you're looking at. What's generally acceptable is roughly about, and what Doug mentioned, 40%. We have 35%, so about that range, 35 to 40% of people with IDDD also experience mental health disabilities. So we're talking about a good portion of the IDDD population that has these needs. In addition to challenges around understanding the prevalence, there's also challenges in adequately supporting people with co-occurring IDDD and mental health disabilities, and serving them well in the community, given the complexity of this population. I mentioned earlier that they're the most likely to be institutionalized or the last to leave institution. We hear a lot about them cycling in and out of institutions, being stuck in emergency departments, being stuck in child welfare agencies, just basically not being adequately supported in the community. And there's a number of reasons for that. Some of it is because of what I mentioned earlier in terms of diagnostic overshadowing, where a mental health disability might go undiagnosed as behaviors or symptoms are misattributed to the intellectual and or developmental disability. It also is because of the outdated idea that people with IDDD cannot benefit from treatment, and that is perpetuated in some of the federal policies that we have. And it's also due to the limited training for mental health professionals for treating people with IDDD. There's a real lack of specialists who can treat people for mental health disorders, but also lack of community capacity in general to provide the kind of specialized services that people with co-occurring IDDD and mental health disabilities need. We also hear a lot about fragmented systems where there are silos between the behavioral or mental health systems and the DD system, and the importance of needing to create bridges and better coordinate across those systems to better serve individuals. So given the long ongoing issues and challenges that this community faces, to adequately live well in the community, we have been doing quite a bit to address this issue. For several years, we have been investing in projects to provide national and state level resources to strengthen services and supports for people with co-occurring IDDD and mental health disabilities. Currently, the Biden administration has really prioritized support for people with behavioral health needs in general. But what's important about that is inclusive of their strategies around support for people with behavioral health is support for people with co-occurring IDDD and mental health disabilities. So we're experiencing a time of great federal support and leadership support within the administration about the importance of providing adequate supports to people with mental health needs. So there is a tremendous focus on solutions that will really work towards helping people live well in the community with a mental health disability. Like I said, we have funded projects in the past, and we're currently funding 2 separate grant programs to address the needs of people with co-occurring mental health disabilities and IDDD. One of the projects that we're funding are 5 grants to our University Centers for Excellence in Developmental Disabilities. And these grants are designed to support state teams that are comprised of DD and mental health agencies, and supporting them in developing and implementing shared training infrastructure or a shared training infrastructure that will improve coordination between the DD and behavioral health or mental health agencies. So working through our university centers, they have connected with the state agencies and convened multidisciplinary state teams that not only include the staff of the state agencies, but also other key partners to work together to really figure out how to break down those silos and develop the training that's needed to work across the agencies to support people with co-occurring IDDD and mental health disabilities. Our hope is that once the state has that infrastructure figured out, they will then work with local level teams to replicate the same model that is at the state level, to build the capacity at the local level for that kind of coordination and collaboration. So with those grants, we are in the states of Alaska, Illinois, Kentucky, Ohio, and Utah. And then last fall, another project that we have funded is the National Resource Center on Co-occurring IDDD and mental health disabilities. And this is a grant that was funded to the National Association of State Directors of DD Services. So Mary's going to spend more time talking about this resource center. But basically what we're trying to do through this initiative is to support individuals with IDDD and mental health disabilities to live well in the community by targeting resources and developing toolkits and providing information that will help states and local communities develop the systems that are needed to, again, support people to live well in the community. Through this work, and this is one of the things that's coming out of the support of this administration, is collaboration that we're doing with both the Substance Abuse and Mental Health Services Administration, or SAMHSA, and the Administration for Children and Families. We have been connecting with SAMHSA on the work that they're doing with their 988 lines, the Lifeline centers, so that if they get calls from either people who have a co-occurring IDDD and mental health disability, or an individual who might be supporting a person with that dual diagnosis, that the Lifeline staff have the tools and the skills to be able to support a person who is in crisis, and will be able to call the Lifeline Center to get assistance. So we're working on connecting the resources for the 988 centers with our center that we funded last year. And so that's collaboration that's just getting underway. And then I mentioned a little bit earlier that sometimes we see a lot of the kids with co-occurring IDDD and mental health disabilities being stuck in the child welfare system or being served in the child welfare system. And so we are connecting with the Administration for Children and Families to figure out how we can partner with the child welfare agencies to support better collaboration there. But before I turn it over to Mary, I just want to, reiterate the real needs, significant needs of this population, and the importance of collaboration and partnership to bring solutions to the table that will really support this hard to serve population that really deserves to live well in the community. So I thank you for your time today, and I will turn it now over to Mary, who will share more about the new center that we have just funded.
Thank you so much, Jennifer. It's an honor to follow you, and thank you, Doug, for your warm introductions. I will be sharing some slides if I can figure out my technical challenges, but just double checking you can see these. Can you see the slide deck?
Yes, we can see it.
Thank you for the verbal. Sorry about that. One of the things that Jennifer mentioned is the prevalence of individuals who have cognitive disabilities and mental health. And while there, I think are some ranges that you heard about in those statistics, there's an overwhelming number of individuals who have these needs. And so our systems have to do better on really recognizing those intersectionalities of disability and just recognizing that individuals aren't monoliths. I think for many years, we've presumed that individuals with IDD cannot have or cannot benefit from mental health treatment. And we've really got to work hard to debunk some of those myths and misperceptions. So one of the things we wanted to share was just a landscape of the services, the challenges that we're seeing nationally. And knowing the work that you all do day in and day out, I suspect you're seeing this very acutely on your own day-to-day operations. But we still really struggle to provide community mental health services for individuals with IDD and other cognitive disabilities. You certainly heard from Jennifer some of the reasons why clinical support for individuals with IDD might be elusive, but it's a nut that we really have to crack. And in that we have, I think an opportunity with the landscape that the federal government is setting right now, and I'll talk a little bit more about that, to really have an increased openness among clinicians to support individuals who may communicate atypically, and to think about ways to accommodate services without necessarily changing the evidence base of the practices or interventions that are involved. And so we're really wrestling with that. And unfortunately, what happens is it winds up being these acute situations, and as Jennifer mentioned, very significantly disturbing situations where individuals might be boarding in hospitals for months at a time, or becoming stuck in an incarcerated state because there haven't been enough clinical and supports in the community to help the individuals transition. And that's just unacceptable. And I think we're all coming to the notion that we need to, of course, have some short-term solutions, but we've also got to have a long-range vision for what this continuum of supports and services might look like. And so we're seeing the individuals with co-occurring IDD and mental health situations, especially those with very significant needs, really stretch the service delivery systems. And as a bit of the foreshadowing that you heard from the prior speakers, our service delivery systems often were set up around a monolith and an expectation that an individual might have one disability, but not co-occurring issues. And again, we've got to come together in that notion of partnership to really devise strategies that can serve the whole person, recognizing that the human existence is complicated and folks don't fit into one box or another. We also know that in many states, states are working hard to try to develop community capacity. And those efforts are exacerbated by a direct support professional shortage, which we'll talk about in a little while. But it's also prompting some legal action in certain states. And some of the catalysts for change in several states have been lawsuits and really in helping really be wind in the sails for the states to build community capacity across those pieces. And then, of course, the lack of expertise can't be fixed in a day, but hopefully we can begin to make more investments in both the clinical support expertise that is necessary to provide good, strong mental health treatment for individuals, but importantly, also helping individuals that act as supporters, as family members or caregivers, and that those direct support professionals, so that they have skills in their toolbox that can help both identify and effectively support individuals to remain in the service system in the community. And then, of course, we've really got to engage early and often and probably forever to make sure that we are continuing to build partnerships across the medical sphere, law enforcement, crisis care providers, and IDD service delivery system to ensure that we've got muscle memory on how we can support individuals and rally around a person to provide a person-centered approach to supports. So we're seeing some, I think promising practices emerge. There's a growing consensus around the importance of trauma-informed, holistic, and person-centered practices that are really tailored to meet the individual needs. And of course, as Jennifer mentioned, we are extraordinarily thrilled at the national partnerships and initiatives that are emerging. The Administration for Community Living has exhibited tremendous leadership in this space. And I'm thrilled to be sandwiched between ACL and SAMHSA on a panel, because the partnerships between those two agencies has been just remarkable. I think the recognition and the commitment to this work is unprecedented and fairly historic, and I think sets the wonderful table for promise moving forward. And of course, the investments that are being made, I think, will help burgeon the service delivery system that heretofore has been cobbled together for individuals with IDD and mental health support needs. And I'm using that term fairly inclusively because we also recognize that individuals with IDD also might have substance use issues that require support. And we as a totality of a system haven't necessarily tended to those in the manner in which we should. We're also really trying to identify the importance of early relationship building and multi-system interventions. Jennifer mentioned the prevalence of children with disabilities that are in the foster care system. We know that better partnerships with foster care and education can help the adult systems of support better prepare and hopefully smooth transitions for individuals as they make those life changes. But again, we've got to do better at interceding earlier and really building those relationships across the service delivery systems, and really building in the architecture to nurture those and continue those so that it doesn't become person specific in the state, but instead really an expectation of system collaboration and cross-system initiatives to support individuals. So as we're recognizing the key elements to supporting individuals with co-occurring IDD and mental health needs, you'll see this really be a bit of a prelude to the discussion we'll have on the Technical Assistance and Resource Center that ACL has funded, which we're very grateful for. But we're recognizing the importance of a few things. The elevation of the voices of individuals who have living experience with IDD and mental health services is essential. We cannot design services and supports that meet the needs of individuals without talking to them about what's going to be most advantageous. And so really creating a space, a safe space for individuals to voice their concerns and really have input into the landscape is so very important. We are recognizing the importance of policy modernization. Again, as Jennifer mentioned, we're dealing with quite a few anachronisms in our service delivery system about that really revolve around preconceived ideas around the capabilities of individuals with IDD to experience mental health conditions. And importantly, that's manifested in these false dichotomies. So you might have in your state, for instance, something where for rehabilitative services in Medicaid are the predominant way many states deliver mental health treatment through the Medicaid program. And in some states, there's really still a vestige of if the individual has a primary diagnosis of IDD, then they're not eligible or won't benefit from that service. And that has really had detrimental effects of real monumental proportions, both in the very, plain and obvious way of not having access to services that are necessary, but it's also deterred providers from really stepping into the space to provide that clinical support. And so we've got some time to make up on this particular area of policy that it continues to be persistent in several states, and we really hope to crack that code here soon. But we also know that in addition to having great access to mental health supports, including those mental health supports to ameliorate crisis and acute situations that we're dealing with, we've got to build a better system of community supports to meet the needs of individuals with co-occurring IDD and mental health issues. Oftentimes, our service delivery systems may have, again, evolved focused on one or the other, but there has been a dearth of community supports available that really take into account the totality of the support needs of an individual and building in the trauma-informed care and the recovery orientation that individuals with mental health supports need, while also really bolstering the community integration aspects that are emblematic in many IDD systems. So we're really focusing on trying to build that capacity out. But of course, none of that can happen unless we collaborate across our state agencies. And so I think we're at a point, both thankfully, we have great models at the federal level who are showing us the way on partnering across the various silos to come to the greater good in support of individuals with IDD. And so we're thrilled to see, I think, a lot of movement in that regard. But we're recognizing that the traditional partnerships, between Medicaid and the IDD agency are essential but not sufficient. And we really have to have many more people at that table to think about a holistic approach to supporting individuals. And really problem solving for the individuals that challenge the system the most winds up having this wonderful effect of creating a more nimble and responsive system for everybody who's supported. So we're also seeing, I think, a recognition that these investments aren't just for the small number of individuals who probably every governor or IDD director or mental health director can name in their state, but instead it really raises all boats within the service delivery system. And then, but really, again, just to reiterate, not losing sight of one of these elements for focus on the other. So really thinking we have to build up, the challenge I think we face is that we have to do all of these things, build up community support systems, build up clinical capacity, really overcome myths and misperceptions about individuals with intellectual and developmental and other cognitive disabilities, and really reframing our thinking. And that goes really across the spectrum of individuals that we hope to support. We recognize too that individuals from underserved communities or who speak different languages, including those who don't use spoken word, are often left on the sidelines in these conversations. And we want to make sure that we're making sure that we are including them. So the other thing I'll just touch on really quickly is we can't have a conversation about building capacity either in the community or clinically without recognizing the direct support professional workforce shortage. This is a pernicious problem that we have known about for many decades, but it's, COVID certainly exacerbated, and we're all recognizing it as a systemic crisis at the moment. And these issues are a problem for our service delivery systems writ large, but they are exacerbated for individuals who have co-occurring IDD and mental health conditions, because the skill levels and the challenges that DSPs face are sometimes exponentially higher, and we aren't necessarily at a point in our systems to support them so effectively. And so that's, I think, an urgent call that we need to meet sooner. And then we also need to arm the direct support professionals in all of our programs with the skills that they need recognizing the various jobs that they do. We often talk about direct support professionals as if they too are a monolith, but we recognize that they really help individuals in all various different aspects of their lives. And so we really must make sure that all direct support professionals are armed with a trauma-informed lens, and also recognizing that they are often individuals of color, folks who might also struggle with socioeconomic challenges, and really recognizing that as we look to support individuals with IDD, we also have to look to support the direct support professional workforce with whom we work. And just a note here, it probably won't surprise you that every state in the union has an eye on these issues and has made investments in trying to shore up the service delivery system and the direct support professional workforce. And through the ARPA spending initiatives, through 9817 of the American Rescue Plan Act, many states have made investments in wages, bonuses, and other benefits to try to attract and retain workforce longer term. So essentially never before has it been more clear that the need for federal, state, and partner efforts are essential to devise those long-term efforts. And thankfully, ACL really saw that vision and has taken a great step in setting that table. So we are thrilled at NASD's to be partnering with our partners at the National Association of State Mental Health Program Directors and at NAD, the National Association of Dual Diagnosis, on leading this effort. We recognized several years ago, SAMHSA had called a roundtable before the pandemic on the issue of IDD and mental health. And we recognized the importance of our organizational partnerships if we really wanted to move the needle forward. Each of us working independently was like parallel play and didn't move the ball down the field. And so we really recognized then that we had to partner together on several initiatives. And that was all a precursor to the work that we've got going now, thanks to ACL. In addition to the three organizations that I just mentioned, with the Resource and Technical Assistance Center, we also knew that we needed to enlist partnerships from different expertise areas and living experience. And so for the Resource Center, in addition to the three partners, we've got the Green Mountain Self-Advocates as partners, Autistic Self-Advocacy Network, Communication First, which is an organization that advocates for individuals who don't use spoken word to communicate, and the Nisanger Center at the Ohio State University, the Sonoran Center for Excellence in Disabilities in Arizona, and the Center for Start Services. And then importantly, as you heard Jennifer describe, and is really that ongoing effort to pull the partnerships together at the federal level. And ACL's just been doing a tremendous job of that with pretty historic meetings across ACL, CMS, SAMHSA, the Administration for Children and Families, to really have candid conversations about what each of the agencies can do and how they can work together to further those pieces. So this is just another visual of our partnerships that are leading the Resource Center collaboration. But I pointed out just because we recognize we want to make sure that living experience is guiding everything that we're doing. We're also recognizing that the individuals with cognitive disabilities writ large, in addition to those just with IDD, need to be at the table in designing these support systems. So you'll also see that the National Association of State Head Injury Administrators has joined our team, which we're thrilled about. The goals of the Resource Center are lofty. Our hope is to ignite systems change, merely making some improvements in policy, service design, and service coordination. And I'd say that's both at the federal level, but we also hope to be a model for the state level engagements so that good practices can be scaled and disseminated more swiftly. And we hope that the Resource Center can be a catalyst in that. We also hope to identify strong resources with the direct support worker and the clinical capacity building because we recognize that the service delivery system has great room for improvement in those areas. And that we need to build a sustainable system of support for individuals. And we're making up for lost time, to be honest. But importantly, we're also with an eye toward the service access pieces. So making mental health treatment and supports, as well as really technically savvy community-based supports widely available to individuals with a really keen focus on diversity, equity, and inclusion. It might not be happening in your state, but we recognize that sometimes our systems are so complex that we leave people on the sidelines. And we need to do a better job of having visibility in the individuals who aren't making their way to the front door of our service delivery system and doing that outreach to make sure that our systems are as inclusive as they possibly can be. The other piece that we'll talk about is just some of the facets of the Resource Center. And this, again, kudos to ACL for their vision in designing the work here, but we've got a lens of diversity, equity, and inclusion in everything that we're doing. And we're also trying to inculcate a notion of continuous quality improvement in the work. So we've got at the core of the project, and I am very thrilled to tell you that we have just identified and have seated our steering committee, which is comprised entirely of individuals with living experience of both IDD and mental health concerns, and they will guide the work of the center. And so we have our first steering committee meeting next week, and I could not be more thrilled. The real vibrant discussions we've had already with our steering committee members promise to bring both a huge lens of personal experience, but also of accountability as this work goes underway, that make sure that we are having the voices of individuals with disabilities really steer this effort. And so from there, we'll be convening some shared learning groups across 5 areas of focus with families, individuals, clinical professionals, direct support professionals, and policymakers. And our hope with those shared learning groups is that it becomes a bit of a community so that we can share among ourselves, but also across those different groups, and that we're continually being inclusive. So we're working through logistics at the moment just to make sure that we're facilitating that in the best way possible, while being completely informed by the steering committee recommendations on those elements. We're also trying really hard to make sure that we harness the interest in this work. It might not surprise you to know that when we did the recruitment for the steering committee, we had overwhelming response, both from individuals with living experiences, but also other professionals who are really interested in the work. And so we want to make sure that we are not losing any of that interest, and in fact, really trying to harness that for the work that we've got ahead of us through the next 4 years of the grant. And importantly, we'll have a website developed and a resource library that will be available and accessible. And our hope in that development of the resource library is to make, obviously, things really easily accessible, and leaning heavily on the other ACL funded projects who have done a tremendous amount of work in this area, but also identifying perhaps where there might be gaps or where there might be resources, but they might not be as accessible to the whole universe of people we hope to reach. And so we really want to have an eye toward building accessible resources and making sure that individuals with intellectual and developmental disabilities can be really important voices in their own supports. And so really arming folks with the tools that they need. And we're also increasingly recognizing that plain language is a help to a lot of people, not just individuals with disabilities. And it makes the knowledge translation that much more important, or that much easier, while it's also importantly sort of overcoming the vernaculars of our service delivery system that often serve as impediments for us to communicate with one another. So we've got our eyes on several different lenses on that piece. And then ultimately, we really do hope that we've just got a sustainable resource that keeps this issue at the top of mind as we move forward, and hopefully as we really chip away at some of the challenges that have persisted. So this is just another visual of the work that we've got coming and some key project outputs, including, as Jennifer mentioned, some toolkits and training curricula, also elevating other good practices that are out there and trying to identify strategies that are scalable and replicable across the country. And we're so excited to be helping really make some connections with SAMHSA and the 988 and Lifeline. We want to make sure that that those important resources are as available for individuals with cognitive disabilities as they are to everyone else, and recognizing that that's going to necessitate some bridge building and information sharing at the state level. And so we're just really thrilled at SAMHSA's attention to these issues, and just extraordinarily optimistic that now is our time to really make perhaps some great progress on an issue that has really, I think, hampered individuals' opportunities to thrive in their communities for some time. So I'll stop sharing now, and I'm probably over time, but just thank you very much for the opportunity to talk with you.
Thanks so much, Mary. That was great. And next up, we have Nancy Kelly, Branch Chief, Mental Health Promotion, Division of Prevention, Traumatic Stress and Special Programs. No, that's AMSA.
No, it's all good. I was going to use the abbreviated version. That's okay.
Next up, we have Nancy.
Too many names. Too many. Yeah. Thank you, Doug. Happy to take it from here, and thank you to my colleagues for referencing the 988 and the work that SAMHSA does and the collaboration that we so proudly take part in. SAMHSA is Substance Abuse Mental Health Services Administration. We are the smallest optive in Department of Health and Human Services, and we are primarily a granting agency. And as in our title of our organization, Substance Abuse Mental Health Services Administration, it encompasses everyone. It's all inclusive. And while we don't primarily create programs specific to individuals with developmental disabilities, we do, all of our programs that we do have, all of our grant programs are absolutely open and inclusive of all those populations, all of those people. And so we work really hard with wherever our programs come out, communities they come out to, that they are open to all, and we keep diversity, equity, inclusion across the board in all of our work. And I think that's also why we value our work with ACL, ACF, and our other colleagues, the prior speaker, making sure we collaborate those agencies that do specifically work with that and integrate our strategies and programs so that they piggyback on and work smoothly together. So a little bit about what we do and how we fit into this. You know, everyone has mental health. Everyone, all of us do, regardless. So the programs in the three branches that I am involved with in the division of, that Doug so eloquently said that I cut him off, the Division of Prevention, Traumatic Stress and Special Programs, which, fun fact, we just this week were announced that we're changing our names again. So Doug, next time you'll have to memorize all new names. But anyway, there's a child and adolescent family branch, and there's an emergency mental health and traumatic stress services branch, and then my branch, the mental health promotion branch. We all fit in this division, and it's considered it's called or thought of as the children's division. So all of the programs and services that we support and fund across the nation and territories is related to children, their families, and adults who serve children. So the programs within these branches focus on a spectrum of services, including prevention and mental health training, serious mental illness in early childhood, adolescence, and transition age with support for families and caregivers, trauma-informed care in school-based mental health and communities, childhood trauma, and disaster behavioral health, including crisis counseling. In addition to these programs, we also oversee the Centers of Excellence and Technical Assistance Centers with a focus on childhood trauma, eating disorders, impact of social media on children, infant and early childhood consultation, system of care, family support, and disaster response. So as you hear about the programs in our division, I'm going to focus on a spectrum of services, with many focusing on the needs of children, youth, young adults, and families, including those children, youth, and young adults diagnosed with co-occurring disorders. And I'm going to highlight some of those programs for you. And I do want to just add that I am by training a special education teacher and school administrator. So I really enjoy doing this work around meeting the needs, making sure that we're meeting the needs, mental health, behavioral health, substance use needs of all populations. And a lot of our programs are school-based, actually. So let's dive into a little bit of data first, just to ground us in where all of these programs are and why it is so very important. So I'm going to touch briefly on the data that shows us trends in children's mental health. So according to the Youth Risk Behavior Survey conducted by the CDC between 2011 and 2021, the percentage of students across every racial and ethnic group who felt persistently sad or hopeless increased. The percentage of female students who seriously considered attempting suicide, made a suicide plan, and attempted suicide increased. Nearly 60% of female students and nearly 70% of LGBTQ+ students experienced persistent feelings of sadness and hopelessness. In 2021, 18% of high school students made a suicide plan during the past year. Female students were more likely than male students to make a suicide plan. LGBTQ plus students and students who had any same-sex partners were more likely than their peers to make a suicide plan. In 2021, 10% of high school students attempted suicide one or more times during the past year. Female students were more likely than male students to attempt suicide. In 2021, 15% of high school students were bullied on school property during the past year, and 16% of high school students were electronically bullied, including through texting, Instagram, Facebook, or other social media during the past year. Also, according to the National Survey on Drug Use and Health 2021 that just came out this year, among 26 million adolescents aged 12 to 17, 5 million experienced a major depressive episode, out of which 3.7 million experienced a major depressive episode with severe impairment. We also know that there are protective factors which can impact the mental health of young people in a positive way, such as opportunities for development of skills and interests, clear expectations of behavior, physical and psychological safety, and mentoring and support for development of skills and interests. Through the programs in our division, we support children and youth mental health in various ways. And so we really focus on those protective factors. How do we influence protective factors, build the resilience, the adults and the children and youth? And we also know that these statistics, as really impactfully disturbing that they are, we know that they have not gone in the right trend since COVID, and that we have seen these percentages get even more dire for our young people. We also know that children, these aren't just typical, what we would consider typical children taking these surveys. These are all children in school taking these surveys and answering these questions. So there is not a youth or a child that is not impacted. So some of the programs that we really take pride in and that we support and are geared to address those statistics and that data that I just shared with you. One of them, and also are most likely to cross-sector with individuals with developmental disabilities and perhaps mental health challenges, is the Children's Mental Health Initiative. So this was created in 1992, and this Children's Mental Health Initiative, which we call CMHI, addresses the gap in children's mental health by supporting systems of care for children and youth with serious emotional disturbances and their families to increase their access to evidence-based treatment and supports. This program funds the CMHI program as well as a sub-program focused on clinical high risk for psychosis. In FY 2023, SAMHSA awarded 42 CMHI continuation grants and awarded a new cohort of 6 grants and a technical assistance center in 19 of those clinical high risk for psychosis grants. Thus far in 2023, CMHI has trained 6,296 individuals in the mental health and related workforce in specific mental health related practices, activities, performed 68 policy changes to improve service delivery and reduce system access barriers pertaining for youth, contacted 41,906 through program outreach, and 7,109 youth received evidence-based mental health services as a result of the grant. And thus far in FY 2023, the Clinical High Risk for Psychosis program has screened 697 individuals for early psychosis symptoms, provided outreach to 2,526 individuals, and made 256 referrals to other mental health or related services. These are children. These are individuals, but all of these are children that were, that this data is around. That many children and youth were served. Another grant program that we deliver is Healthy Transition. So this Healthy Transitions program has comprised several iterations of the program since its creation in 2022. So it's fairly new. The program began with the Partnership for Youth Transitions in 2002 to 2004, followed by the Healthy Transitions Initiative in 2009, 2014, and then the Healthy Transitions, Now is the Time, from 2014 to 2019. The current program's iteration is called the Healthy Transitions Initiative, which began in 2018. The purpose of this program is to improve and expand access to developmentally, culturally, and linguistically appropriate services and support for transition-aged youth and young adults, ages 16 to 25. And we know that is an age range, especially with young people with developmental disabilities. That's a really tough transition period because they're leaving high school and they're going into the adult world. And that, in my experience, in my work with the Medicaid waiver autism program in Maryland, that's the population that struggles the most. They have a service gap, and so families struggle and the young adults struggle the most. So these transition age youth and young adults who either have or are at risk for developing serious mental health conditions. And one of the risks affecting transition age youth is that it coincides with the age of onset for most mental and behavioral health challenges. And thus far in 2023, Healthy Transition grantees conducted direct outreach to 2,651 youth and young adults to engage or re-engage them in services, screened 941 young people for serious mental illness, and referred 344 to needed mental health or related services and support. Another really large and getting a lot of visibility is the Project Aware. And this is a school-based infrastructure grant program. So while it also provides direct services and intervention, strategies, training, it also works to and funds to help school districts, state education agencies, local education agencies with the collaboration with their local community behavioral health partners or just local nonprofit organizations to build an infrastructure in where they have policies, procedures that will work to meet the mental health needs of all the students in their schools. So Project Aware stands for Advancing Wellness and Resiliency in Education, and it's made up of 3 components: Project Aware, Recast, which is resilience in communities after stress and trauma, and cooperative agreements for school-based trauma-informed support services and mental health care for children and youth, which we call trauma-informed services in schools. All 3 of these programs are a part of a comprehensive mental health project that focuses on building infrastructure within schools and communities to provide trauma-informed, developmentally appropriate, and culturally competent services to children and youth, their families, and their communities. It was established in 2014, and Project Aware grantees develop collaborative partnerships that include the state education agency, the local education agency, which would be the school district, tribal education agencies, the state mental health agency, community-based providers of behavioral health care services, school personnel, community organizations, families, and school-aged youth. It was established in 2016, Recast grantees support efforts in high crime, high poverty communities that have experienced civil unrest, community violence, and collective trauma within the previous 24 months. And established in FY22, trauma-informed services in schools grantees increase students' access to evidence-based, culturally relevant, and trauma-informed mental health care by developing innovative initiatives, activities, and programs to link local school systems with mental health systems and support, including those under the Indian Health Service. Thus far, in FY 2023, Project Aware grantees trained 67,904 individuals in mental health and related practices, screened 84,112 children and youth for mental health related concerns, and referred 24,353 children and youth for mental health services and treatment. And thus far in FY23, the Recast grantees trained 1,690 individuals, reached 41,611 community members with mental health messaging addressing trauma-informed practices and provided evidence-based mental health-related services to 2,371 individuals. Another program, if we want to think big, are the statewide family networks. This was initiated in 1993, and the Statewide Family Network Grant Program provides education and training to increase family organizations' capacity for policy and service development. And this is accomplished by strengthening organizational relationships and business management skills, fostering leadership skills among families of children and adolescents with serious emotional disturbance, and identifying and addressing the technical assistance needs of children and adolescents with serious emotional disturbance and their families. Thus far in 2023, Statewide Family Network grantees trained 6,198 people in prevention, mental health promotion, and mental health related practices and activities, including those in the mental health and related workforce, and involved 2,031 consumers and family members in ongoing mental health related planning and advocacy activities. Some of the challenges that we are hearing about from our grantees include workforce shortages and lack of opportunities for children, youth, young adults, and their families to get connected with the needed resources, lack of opportunities for respite care and workforce training opportunities for young adults with co-occurring disorders. While this is not tracked through the data, the CMHI and Statewide Family Network grantees in particular work with many families with children and youth diagnosed with both serious emotional disturbance and developmental disabilities. We have lots more to do, lots more work, and we can't do it without our partners that are doing this alongside of us in the Department of Health and Human Services. So thank you very much.
Nancy, thank you so much. That's amazing. Next up, we actually have from boots on the ground in a county in Sedgwick County, Kansas, Sherry Arbuckle and Nick Wood, and they're going to be able to share what's happening in Kansas, what's happening with the individuals that they support, and bringing it all together. And with that, we have some slides. We have some data that came out of their MediSked system, so that's kind of cool. And Sherry and Nick, take it away.
Well, good afternoon. I'm kind of in awe to follow all of the speakers we've listened to this afternoon, and very excited about some of the things I'm hearing. I was asked to give an overview of Kansas and our CDDO system, and also some of the challenges that we're experiencing here in Sedgwick County. So to start off, I just want to give you a brief overview of some of the history, how our model kind of evolved. In the mid-90s, advocates, providers, legislature, state policymakers came together, and they developed what we call the Developmental Disability Reform Act. And that law was enacted in mid-1995. And in that law was the creation of what we call the CDDO system. The CDDO system is required by law. The law dictates that the counties have to either manage the IDD system, or they have to designate somebody within their catchment area to manage the IDD system. And so in that process, there were 27 CDDOs developed across the state of Kansas. Many of those CDDOs manage large rural areas, especially the western part of the state, as you can see in the map. Sedgwick County and Johnson County would be the two largest CDDOs population-wise, and some of the CDDOs are not-for-profit organizations that have been designated by the county government, and then some county governments have maintained the CDDOs within county government, and we would be one of those CDDOs. The CDDOs are responsible for a single point of entry, and just I'll put my sibling hat on and my historic IDD system hat on. And prior to the development of the law, if you were a family and you were seeking IDD services or supports in the state of Kansas, you would have to knock on many doors. You would have to go to multiple providers, fill out multiple applications, and try to get your foot in the door with a provider. And that, with the enactment of that law, that reduced that burden for families, and they could come to one single entity within their community, and they could make application for the IDD system. And so the CDDO is responsible for determining eligibility for the IDD system. And then we also have the obligation, responsibility to do the level of care eligibility determination for a funding stream, which is the HCBS MR waiver. Or I should say IDD waiver. We are also responsible for managing the network capacity, the quality oversight, and then also, we're referring individuals into the community for other options if we believe they need connected with local resources in the community as well. Now, Sedgwick County in particular, we have 2,700 individuals determined eligible for the IDD system, and 18% of the entire state population. So you can imagine that, those are quite a few individuals to have the responsibility for making sure they're connected in the community to resources, connected to local funding sources, connected to state funding sources. And so that is, it's a pretty big lift for Sedgwick County to manage that size of population. As I mentioned earlier, we're responsible for single point of entry. We do the functional assessment. We also do all of the options counseling. Once an individual has access to funding, we can talk to them about our network of providers and who might be a option for them in the community. We can also look at options outside of our community by referring to other CDDOs. We also have the responsibility of making sure that individuals maintain their placement on the HCBS IDD waiting list, which is a statewide waiting list. And then we also have waiting lists for local resources. We do all of the quality oversight and network management for approximately about 50 providers in our community. And on the topic that we're here to discuss today, one of the things that that I've experienced in working in the system in the IDD system since the 80s was that our population, we're seeing significant changes. We are seeing individuals with more complex needs, needing access to mental health supports. And you can see in this slide, 46 of our population that is determined eligible for IDD services in Sedgwick County alone have these cohorts. They meet, you can go to the next slide, Doug. We can kind of go over, we have an assessment, and in that assessment process, we go through, and there's several indicators in that assessment that talks about the behaviors, the supports that the individual needs, and there is a scoring mechanism that's given to us on the developmental disability profile assessment that will help us gauge what their maladaptive health needs are. And I won't read this slide to you. I know we're kind of short on time, but these are some of the indicators in one of those questions. The other data that's collected is how the frequency of behaviors, how often they are occurring. Now, the assessment we currently have in place does not collect the intensity of those behaviors. We are transitioning potentially in the next couple of years to the inner RAI, and we have customized that to start collecting information on the level of support needs needed, the intensity of the behavior. And so we're hoping to get some additional data from that assessment as we move forward with it. We also included some information in this presentation about the high medical needs of our population. And these are some of the indicators in that assessment. So what we are finding is that we not only have the complex needs of individuals that have IDD, mental health needs, significant interfering behaviors, but we also, part of that population is also, as they are aging, starting to have a lot of medical needs as well. So the population has become just a lot more complex in how we have to be flexible, creative, and how we're going to meet the needs of our DD population in our community. In 2022, we had 601 individuals that were currently on our waiting list. That means they are not receiving any level of support at this time with interfering behavior. So we're starting to look at, the trends coming in the future, and it doesn't seem to be changing. I think if you look at those numbers in the slide, 64% of those waiting for HCBS. So that's a significant concern for our area. Of the 1,559 individuals with interfering behaviors, 836 had high medical needs as well. So, just a lot of complex needs. I've worked in the system since the late 80s, and it continues to be a concern that we are really challenged with how we're going to meet the needs of these individuals. We are challenged from at the level of policy. We are challenged at the level of funding. We are challenged at the level of locating staff that want to work in our communities with this population. Our providers report to us that they are struggling to find DSPs, as all of you probably are in your areas as well. But when they start talking to them about working with this challenging population, there becomes an additional capacity concern because individuals are just very reluctant to want to work with this population. So next slide, please. Okay. We looked at our data, and there is a list of 10 diagnosis that we pulled. Now, the information we have is only as good as what is reported to us. And some individuals, the information we would have received is when they initially came to us. And we may not get updated information for a period of time because they've not actually been pulled from the waiting list to receive services. But we can tell you from the population that we do have in services, these are some of the diagnoses that we're seeing with that population. We also are experiencing, when I talk with my staff, we have a lot of individuals that come through to us that have the autism diagnosis when they're young. And we are looking at these individuals are starting to exhibit other things that may have indicators that they might have been misdiagnosed in their youth. And so that is probably a challenge that we've really seen in the last couple of years. We have to be really careful when we're working through eligibility that we're getting good information, because if we don't get good information when we are trying to intake the individual, that's not going to serve them well as they work through our service system. So those are some of the things, if my staff were on, that they would share with you as well, is getting, good information. And I talked a little bit about funding. We do have the ability for our providers to apply for extraordinary funding. And in Kansas, we have 3 MCOs that manage the Medicaid funding for the state of Kansas. And they are the entity that is responsible for doing the extraordinary review. Now, I wouldn't say that this is a completely new issue for Kansas, but I would say it's become more difficult for individual or providers to get access to extraordinary funding just because of the lengthy process to get through that. As you will see on the slide, an individual, a provider would have to take a loss for a year before they can make application for extraordinary funding. And many of the providers are reluctant to go through that process because you would have to document all of that. There's a lot of paperwork that goes into collecting or completing the application process. So of the network that we have, 17 of those agencies that provide day and residential did apply. Only 9 of them applied for EF funding in 2022. Of the 9 agencies that applied EF funding, only 8 agencies were successful in getting their applications approved. And I called it out a couple times in here, and it's probably because when I looked at this number from our capacity report, it was just really alarming to me, the size of our network that we have and the number of individuals that we have on HCBS-IDD waiver funding, that only 33 individuals received funding across 8 approved agencies, which to me is somewhat of an alarming figure, when we should have a lot more individuals based on the data we have. The capacity issues we're having due to our providers are really struggling to meet the needs of this population. That is what we have approved in our county. So just a little shocking to see that number. As I talked about, the application process is somewhat lengthy. Providers are reluctant to go through it. And this slide really talks about, having that year that you have to basically function in the red before you make application for funding. We would like to see some changes in Kansas made to that process. And it's something we definitely need to be working on based on this information. Capacity issues for the dually diagnosed. I talked a little bit about that. I did want to share an example with you, and maybe this pulls my heartstrings more because, I'm a sibling as well as an employee of the CDDO, and, to put myself in this family situation, it is something, it's a situation that over the years that I've worked in the system, I think this is a case that probably has bothered me more than most. We had an individual that she was having a very difficult time in the community. She was self-harming. She was in and out of the local hospitals. She was just really struggling. The provider was struggling to serve her. She did go into one of our psychiatric hospitals for an evaluation. And we did go through the gatekeeping process. And in the state of Kansas, when we refer to the gatekeeping process, that is making application for the developmental disability state hospitals, the ICFs. We have 2 of them in the state of Kansas. And we made application for her, and she did meet what they call the active treatment needs for the DD State Hospital. But unfortunately, due to her very violent behavior and her self-injurious behavior, our state hospital said that they could not meet her needs. And she has been in a psychiatric hospital, and they have not really been able to manage her either. She currently spends most of her time in mechanical restraints. I have staff refer to them as belly chains at times, that when they have her outside of her cell, they can't manage her. And she spends most of her time in that cell because we do not have a place in our state system that can meet her needs. And the MCO has been desperately looking for options for her outside of the state of Kansas. But they have been unable to locate anything for her. There were discussions at one point about trying to return her to her home community, which actually wasn't Sedgwick County, to live with the guardian. And, there was no level of support that we could put into that home that would allow her or ensure her safety or the safety of others. So at this time, she continues to be in that setting. And I just really struggle with that personally, that, this really, in my opinion, this is a case that calls out the gap in our system in the state of Kansas. And we really need to figure out how we're going to fill this gap. It's just a very unfortunate situation. And I imagine there's some of you that probably have similar cases in your areas. It's just the population that we are trying to meet the needs of has just really changed. there's a lot of challenges, and it's not just money. It's policy, it's staffing resources, it's local community resources. You know, we have tried to work with our hospitals in our community to meet the needs of individuals, but they can only meet their acute needs for a period of time, and then we have to be able to figure out where to move from that point. Unfortunately, we are starting to see that our local hospitals, they're also having capacity problems, and they're a little reluctant to admit somebody because they have a lot of concerns that somebody's going to actually be able to serve them when it's time for discharge. So we are challenged with that. We are also challenged with our population is in and out of the jail system locally. We have individuals that cycle in and out frequently. We do get a report from our sheriff's department daily telling us how many individuals that are in our system have been admitted. And, I would love to tell you that's a small number, and it's not a huge number, but it's enough that we have to put staff in charge of tracking that to make sure that we know that the individuals are coming in and out of the jail and that we're trying to address their needs as they transition. We are also challenged with them losing Medicaid, losing Social Security if they're they're incarcerated for any period of time, which makes finding them a local service provider willing to serve. Although we may be able to get funding put in place to try to assist them, there's still room and board cost, and there are still Medicaid issues that have to be resolved. So there's just a lot of challenges. I would say some success stories in our community. I would give praise to our previous director. She's no longer with us. She's currently a regional director for our Department of Family and Children and Family, and things that she worked on to try to make changes for this population was working with our local college to develop the badge program. What we have found that we have a lot of need in our community for individuals that are treating persons with mental health issues to also be trained on how to work with people with developmental disabilities. So she worked very hard to get this badge program opened up with WSU, Wichita State University, in our area. It is a program that's available, I believe, nationwide. So I wanted to share this information with you in case this is a resource that you might like to look at for your area. She also worked with NAD on developing Train the Trainer training for our community. We've had some success with that. I don't think the success was what we had really hoped it would be. And I will tell you, working with our mental health partner within the county, I think probably the success stories are that we have a very close relationship with our crisis department, and our staff network pretty regularly, and we do have connections with them, and so we can try to intervene and work together as much as possible. We do have close relationships through networking with our medical staff in the jail. So we've had to really look at what we could do to influence change in our community. But it's not been easy. I think there's a lot of work to do, and I'm just, I would encourage the presenters before me to please keep working on this, because this isn't a problem that's going to go away. That's not been our experience in Sedgwick County. So I'm going to leave Nick some time so he can talk about what we've done at a state level, because we have made some progress with our legislature this year that I would like him to share.
Yeah, thank you, Sherry. That was wonderful. Thank you to all the speakers. My name's Nick Wood. I work with Sherry and a lot of the other, or all of the other CDDOs in Kansas, as well as just disability service providers. policymakers, state agencies, and others here in the state capital of Kansas, which is Topeka, to work on these issues. And as you heard Sherry say, I mean, we've had these sort of gaps and barriers in our system for a long time now. We've been living with them. And Sherry gave you an idea of sort of what they do at her level to work around those gaps and barriers at a system level. But of course, what we want are state level policy changes and new models for Kansas. So you heard, I think, from Jennifer and Mary, what a lot of those models and solutions would be. So I won't rehash those, but we definitely are, we want to integrate with 988. There's good momentum there for us to build crisis services across the state. We do have a goal for our ARPA spending initiative, or part of our ARPA spending initiative will be to establish IDD mobile crisis services across the state. And then there's been recent allocation by our state legislature for special funding for crisis stabilization for IDD. So we've been pretty fortunate in recent years. There is good recognition of the problems, the gaps and barriers that exist. We've had state committees, legislative committees really get interested, and individual legislators have really been champions. We're also pretty fortunate here in recent years. We've had a really great cabinet level secretary at our Aging and Disability Services agency here in Kansas named Laura Howard, who has been around in Kansas for a long time. She understands the problem and she supports best practice solutions. So we are teed up, Sherry, to start implementing some solutions here. So one thing that we did that's on the slide right here is in November 11th, we held a pretty the largest stakeholder meeting that I've attended since before the pandemic in Kansas. We had over 100 professionals from Department of Corrections, or IDD providers, or mental health providers. All the relevant state agencies were in attendance. We worked with PRA associates who were here on scene, and they were busy taking notes for 2 days, developed a lot of goals and objectives for us that will come in very useful for these initiatives. So right now we're working with the Center for START Services. We want to bring them to Kansas so that we can take a look at what we have and what we can implement. The 2.1 million that was dedicated as resources by our state legislature will be used to develop capacity, and some of that, just because of the situation we're in, some of those dollars are going to have to go to immediate concerns that we have. People are currently sitting in jails, hospital ERs, and that sort of thing. But what we want for the longer term with that funding is to use that to build capacity and to show that we can develop a sustainable statewide system. You can go to the next slide. So we talked about the 2.1. There's also we have an opportunity in Kansas just because of the timing of these things. We're set to renew our waivers. The IDD comprehensive waiver that we have. We also we have good support from our state agency and the legislature to develop a community support waiver, which will be focused on the needs of people with IDD who are currently on a 10-year waiting list for IDD waiver services, but who want to live in their own home or their family home. So it will look a little different from our comprehensive waiver. We're excited to get that underway. That's going to occur this year, or that's going to begin this year. And actually, Mary came and spoke with us at the end of September to give us some suggestions for getting that underway. And Mary, you'll be glad to hear that they took your advice. So we're moving forward with that. But these are all things that we hope will come together, will integrate well, and will provide some solutions for providers around the state who are desperately in need of those things. So thank you so much.
All right. And with that, to bring it all together, we have Jonah Cunningham, CEO of National Association of County Behavioral Health and DD Directors.
So thank you for the introduction, Doug. And if all the panelists could turn their cameras on, I just want to ask one quick question before we finish up here. So as you reflect on your presentations, if you could leave the audience with one key takeaway that they can take home, they can take to their work tomorrow, one key lesson, whether it's a glimpse of optimism, whether it's a lesson learned that you've lived. So I'll start, I guess I'll go, let's go last to first. So Sherry, are there any lessons or key takeaways that you want the audience to go home with? And briefly, we only have a couple minutes.
To not give up. I know there's times that my staff and we get kind of bummed out because we just seem to be frustrated because we're not making progress. But I would just say, just keep at it, because we have to make progress for this population.
And Nancy?
Well, she kind of took mine. I was thinking perseverance. I would say there really is no wrong door. Just there really is. Don't ever stop asking, looking, and reaching out. That there's no wrong door.
And Mary, key takeaway?
Yeah, I think just that partnerships are essential. It's no longer nice to have collaborative working relationships, but essential to achieve them. And the way that we've done business up to this point doesn't have to be the way we do things in the future. So thank you, Jonah.
And last but certainly not least, Jennifer.
Well, I agree with the perseverance that Nancy and Sherry referenced. I do think that because these individuals are so complex that it's going to require perseverance, so don't give up. But that solutions are out there and that it's feasible. We have seen people with really complex needs who do end up, with the right supports in place, and through that partnership and collaboration and figuring out where's the right door, through that perseverance, that people can live in the community. And even like the individual that Sherry described, which was just so heartbreaking to hear. But even for folks like that, who we think just can't, it's possible. So don't give up hope.
Well, thank you, panelists. Thank you, Doug. Thank you, MediSked, ACL, SAMHSA, NASD, Sedgwick County. We'll be following up in the coming weeks with the recording and resources. But until then, we'll see you next time. Take care.
Thank you, Jonah.
Thank you.
Thank you.
Thank you, Doug.
Thank you, everybody.